Thank you, Dr. Waqar. Thank you for inviting me to do the presentations. It's a pleasure to be here. It's a pleasure to see a lot of friends and colleagues. Today I'm going to speak about unusual site thrombosis. This is outlined in my objectives. I will give an overview of the unusual site thrombosis. What are the challenges facing us as clinicians? And I'll give a quick overview, practical review, mainly of the management of CVTs, splanchnic vein thrombosis, and upper extremity DVT. So unusual site thrombosis. I know we're all familiar with the PE DVTs. Anything outside these locations, they are classified as unusual site thrombosis. The common normally is cerebral, splanchnic, upper extremity, ovarian, and retinal veins. Despite they are a lot, but actually represent less than 10% from all thrombosis. The challenges facing us, it's predominantly much less common than the DVTs and PEs. For example, incidence of PE DVTs 100 to 180 per 100,000 person, while in cerebral venous thrombosis between 0.3 to 0.5 per 100,000. They present in a wide, let's say, different presentations. Some of them, they could be asymptomatic. Some of them, despite they are thrombosis, they present with bleeding. Their workup is completely sort of different from the workup of a PE and the DVTs. So, for example, in a PE DVTs, almost 60% are unprovoked, and 10% have persistent provoking factor, or 30 have a transient. While, for example, in unusual site thrombosis and the cerebral venous, they have almost 80%. They would have a provoking factor. The same apply for the splanchnic, let's say, clots. Higher bleeding risk. Not only higher bleeding risk, some of the thrombosis in unusual site, they present with the bleeding, so that will make it more difficult and challenging to treat. Other challenges we have a limited high level evidence. So let's say there is not a lot of randomized control trial that we can base their recommendations based on them. A lot of the evidence based on expert opinion, or basically weak evidence, observational studies or retrospective studies. Frequency is going up now with the better OVC imaging, especially apply for the CVTs. And it's one of the let's say the presentation that require very collaborative work. For example, in the cases of splanchnic veins, works between internal medicine, hematologist, hepatologist. Same apply for the CVT. Require works between a neurologist. So there's a cross boundaries of specialities. I'll start first with the cerebral venous thrombosis. It's represent around or less 1% or less than 1% of all strokes. The incidence previously thought to be around 4 per million, but more recent, let's say, reviews with the better imaging, let's say, modalities is up between 13 to 16 per million. It's more on the superior sagittal science. It's a disease of a middle age, and tend to be more of middle age and women. So 75% are female. Average age is 34. It's complicated around 9 out of 100,000 pregnancy. And majority of the people, they would have identifiable risk factors, and as well a majority as well, they will have more than one risk factors. But challenging bits, it's almost up to 40% of the cerebral venous thrombosis, they can present with them as well intracranial, or they will have associated intracranial hemorrhage. Their mortality rates varies between 1 to 9% at the time of discharge, and almost 80% they have a full recovery. However, as well, some new studies suggest that up to 40% of people with CVTs, they lose their job. So despite they are middle age, but 40% lose their job if they don't. Hence why it's important to treat and manage, let's say, appropriately. The recurrence rates in comparison to, for example, DVTs and PEs is less. A few reviews is around 2%, or between 1.5 to 2%. Over 3 years, cumulative risk is around 3.5 to 5% max. Factors associated with the CVT recurrence: men having a 9-fold increase, and the recurrence, severe thrombophilia, and as well having polycythemia or thrombocythemia. So these are just to be aware of as a factors associated with the recurrence rates. Otherwise, the recurrence rate of CVTs tend to be more on the lower than the DVTs and PEs. So what are the risk factors? We can classify the risk factors for CVTs are local, which tend to be these, let's say, three, and systemic factors. The local including infections, ENT infections, surgical interventions, and obviously CNS disorders. The more common that we see patients, they are female on hormone replacement. That's the commonest basically cause. Pregnancy and postpartum, and as well MPNs represent around 3 to 4% as a triggering factor. Obviously COVID and the COVID vaccination now. Approximately 20% of people would have a thrombophilia screen positive. So what are their presenting symptoms? Commonest is the headache. So a lot of people, they normally present with the headache. Headache is tend to be the classic of it is more of a raised intracranial pressure, like a diffuse, worse on lying flats, associated, for example, vomiting, early morning. There has been a lot of studies suggest there is a delays of around a week until we make the diagnosis. So be aware of patient that's present in a clinic, or for example, an ER, repeated episodes, young female on contraceptive pills, coming in and out with the headache is CVTs is one of your differential diagnoses. Much more easier, it's associated with the focal neurology. So if they have any motor deficits, comes back next seizures, whether it's generalized or focal seizures, that's what should raise the suspicion of CVT. Investigation, hopefully straightforward. The gold standard at the moment you are using MR and MRV. If that's unavailable, obviously CT would be the other diagnostic tool. Sometimes we do a non-contrast CT and we have an indirect, let's say, changes to reflect to suggest that there might be thrombosis, like for example hemorrhage, and that starts to trigger a further investigation with CT venography or, for example, MRV. The other investigations all depends on the etiology or what are the causes that we think is a trigger for these CVTs as a baseline. For example, thrombophilia secretions or antiphospholipids, or obviously CSF if there is any suspicion of any let's say infection. This is just say a busy slide, but just give you an overview of the treatments, and I might go into details, predominantly focusing on the anticoagulation aspect. Treatment for CVTs, anticoagulations, even in the presence of bleed, even in the presence of a hemorrhage, anticoagulations is the mainstay of let's say immediate treatment. So there is no contraindication. The association of a hemorrhage with CVTs is not a contraindication to start on treatments. The best option to start with, and the most studied, is basically is using low molecular weight heparin or unfractionated heparin. That's predominantly in the acute stage. Low molecular weight heparins will be the first to go with, but if there is any planned surgery, procedures, or anything that you think basically better to control, then unfractionated heparin. The others, like thrombolysis and endovascular, let's say treatment, that's on a very selected cases. Predominantly, the evidence from thrombolysis there, they do improve basically recanalizations. However, it's associated with a much higher rate of mortality. Hence, need to be in only selected let's say cases. After the acute phase, then you decide about the anticoagulations, and I'll talk about, for example, the warfarin and DOAC. Duration of anticoagulation for the CVTs, most of the guidelines, although it's not let's say there's not a lot of large studies, but intend to be recommendations between 3 to 6 months when there is a provoking factor. When there is no provoking factor, intend to be between 6 to 12 months, and only in selected cases there will be long term, and I'll talk about it at a later let's say stages. Other treatments tend to be focused around treatment of the complications. So, for example, if they develop seizures, they'll be needing anti-epileptic. There is evidence of an infection. They require antibiotics. If they develop hydrocephalus, tend to be more of a shunt or acetazolamide. They have a very high intracranial pressure, then CRLPs might be needed, and then decompressive surgery if they have a herniation. So DOAC against basically warfarin. Obviously, from DVT's PE side, there's a lot of evidence and superiority, or at least non-inferiority, of DOACs in comparison to the warfarin. In unusual site thrombosis, and including, for example, the CVTs, is not a lot of, or there is no, other than one at the moment, or two randomized control trial. Otherwise, predominantly all the evidence is based on observational studies or retrospective, basically, studies. So it's being used. It's not like it's not being used, but there is no big studies to develop them, let's say, the evidence. So there has been a couple of meta-analyses. They've used it in comparison to the warfarin and showed good achievement of recanalization and similar or lower bleeding risk. One study, which is the RCT study, which is the RESPECT CVT, they compared dabigatran against warfarin. Again, no recurrence of VT, lower major bleeding in comparison to warfarin. But obviously, as I mentioned, the difficulties is these are all small study. Most recently, action CVT basically published, which is again, it's a retrospective multi-center international study. Over 1,000 patients, been some of them given DOAC and some of them warfarin. This is not an RCT. This is just let's say retrospective multi-center, where the clinician decide to give some patients DOAC and some given let's say warfarin. Predominantly of the patients giving DOAC, they were between apixaban and rivaroxaban and some dabigatran. And as you can see, basically here, there is a similar rate of recurrence, similar rate of death, lower risk of bleeding comparison to warfarin. And as you can see, again, the same here. You can see the difference between the warfarins and DOAC. So that's the action CVTs, one of them studies basically used. So a lot of initially, most of the guidelines for CVTs, they come from different specialties. They come from obviously the let's say hematology societies, but you can see them as well in the strokes and neurology. As an example, the BSH, which is the British Society of Hematology, they updated their 2012 guidelines to include dabigatran can be used after initial treatment with heparin in place of warfarin. A 1B recommendation, just based on the study I've showed earlier, and they've as well included that you can use other factor Xa inhibitors can be considered after heparin for adults with CVT in place of warfarin. That's a 2C recommendation, which is let's say a weak recommendation. Obviously, this study is published after the publications of PSH update. Same ISTH recommendations. That's DOAC can be used in some patients, and they use them let's say traffic light type of presentations in which you can use it in certain patients. Be aware that if they have any medications contraindications, and cautious about when patient there is a malignancy or trauma related. So for CVTs, just a quick recap. Initial treatment, 7 to 14 days, low molecular weight heparin, followed by warfarin, the gold standard. DOACs can be used and has been used in cases. No strong recommendation, just purely because there is no strong evidence, but has been used. There's an ongoing trial, which is a secret trial, a retrospective, RCT, studying rivaroxaban instead of warfarin. Optimum duration 3 to 6 months, 6 to 12 when there is unprovoked, but you have to consider long-term when there is recurrent episodes, or for example, one with the thrombophilia, and possibility in male because the recurrence rate is higher, and possibility long-term as well for patients they have incomplete clot resolution. So splanchnic vein thrombosis, these are the definitions. They intend to be more either in portal. I'll try and go quick just because purpose of the time. It's either let's say hepatic vein, which is a Budd-Chiari, and portal vein, mesenteric vein, splenic. These are the veins normally associated with the splanchnic veins. It's the commonest cause of portal hypertension after cirrhosis. Incidence in Western countries around 10 in 100,000, much lower for Budd-Chiari. Risk factors. Important to know about the risk factors for all the unusual site thrombosis, because your investigations will be depending on that, or the further investigation depending on that. Cirrhosis, cancer, straightforward, but as well, if none of that is present, if the patient doesn't have active cancer or doesn't have any, for example, known cirrhosis, they must be screened for inherited thrombophilia. They must be screened for myeloproliferatives. They should be screened for BNH. Think of Behçet disease. These are the commonest. So screen for JAK mutation. So these are the commonest causes outside the cancer and outside the cirrhosis to cause splanchnic vein thrombosis. Mostly depend on their presentation. The difficulties in splanchnic, they could be present as acute, or they could be presenting as a chronic, or that sometimes they become incidental. So big proportion they come in, let's say, incidental. They can present as a complication from the portal veins thrombosis. For example, a lot of patients develop GI bleed and decompensations of the liver disease. Again, just a quick, let's say, investigations tend to be the standard would be Doppler ultrasound, but depending on what are you suspecting, it might be a CT or MR. Other investigation, depending the goes, depending on the etiology, so JAK2, flow cytometry, if you're suspecting PNH, antiphospholipids, thrombophilia secretions, and OGD, in almost certain, a lot of them, they will require, there is a suspicion of portal hypertension. A previous, let's say, recommendation, the ACCP recommendation to anticoagulate, to divide the patients with SVT, symptomatic and asymptomatic. And their previous recommendation, 2012, is asymptomatic no anticoagulation. This is based on risk of bleeding, and asymptomatic is similar to, let's say, recanalizations. However, more studies now suggest more, even if they are asymptomatic, they should be considered for treatment. The most recent, basically, review for the splanchnic vein thrombosis is the ESL, which is the European Association of Study of the Liver, published in 2023. And they divide the treatments into most important aspects in PVT divide. It's either it's with underlying liver disease or without any underlying liver disease. And then you decide as well if it is a recent or a chronic. Mostly they require anticoagulation, I'll say, for the recent. For the chronic, without any liver disease as well, mostly they require treatment with anticoagulations. However, they suggested in some group you might consider a lower dose. And out of interest, they gave as well rivaroxaban as an option of treatment. While if the patients have underlying liver disease, if the patient is for a candidate for liver transplants, now not necessarily it can be a candidate. So some centers, it's as long as the patients fit the criteria for being a candidate. So it's not necessarily the patients on a waiting list for liver transplants, but they fit the criteria. Then basically they go into this pathway and tend to be more, let's say, treatment anticoagulation. Same applies if they are non-candidate. You look at the difference whether they be anticoagulated or not. DOACs, again, ISTH, nice to say, traffic lights for using of DOAC. You can use it in certain cases. Be aware when you're using it in each patient with GI cancer. So probably all of this, I would try and avoid using DOACs. And obviously should be avoided in advanced liver disease or advanced, let's say, renal failure or thrombocytopenia. But Kyrie is a stepwise approach, anticoagulation long-term, and anticoagulations basically with low molecular weight heparin in the short term, then are followed by warfarin. Extremely rare. Angioplasty, thrombolytic tips is obviously then as a stepwise treatment. Challenging bit is basically the anticoagulation for the liver disease and obviously portal vein thrombosis. Most important things you might have to touch is we need to control the source, or they have a high risk of bleeding. So they almost all they would need an OGD to see if they have any liver disease. They will need beta blockers. They have any esophageal varices. So control of that. The more difficult bit is if they have an acute DVTs and when they have advanced liver failure. Obviously, DOAC is contraindicated and when there is advanced liver disease. Most of them, they are coagulopathic, and the warfarin might be tricky as well to treat. A lot of them as well, they have thrombocytopenia. So the question is, what do we let's say give? The recommendation is using low molecular weight heparin based on expert opinion, and we should consider dose reductions in these patients. These are the, let's say, as I mentioned to you, the expert opinion, let's say, recommendations using half of the dose for patients with liver cirrhosis, thrombocytopenia, and portal vein thrombosis when you've already controlled any source of bleeding. Like, for example, they are on beta blocker, they've been scoped, their esophageal varices in a way banded or under control. Then you use a half of the dose when their platelets between 50 to 100,000. When their platelet between 30 to 50,000, you use a prophylactic dose and no anticoagulation for the patients below 30,000. Summary of as we the treatment, hopefully that's the same. So I'll just try and go quickly to cover some of the upper extremity DVTs. So upper extremities is axillary, subclavian, brachials. 5% of all DVTs, incidence to 2 in 100,000. 1 minute.
Can we give another minute? Just last few slides.
Just last 2 slides. So a lot of similarities between the upper and lower limbs. Risk of a PE with the upper limb DVT. They come with a swelling, pain, functional, let's say weakness. Long-term complication as well, again, similar. Diagnosis similar. Treatment as well, more or less, basically similar. They could be associated with a line, and if there is a line, depending whether the line is needed or not needed, or functioning or not functioning. As a general rule of thumb, if the patients need the line, the anticoagulation continue until you remove the line 3 months after. If the line is not needed, you remove after 3 or 5 days of anticoagulations, and you anticoagulate again for 3 months. The risk of recurrence with the upper limbs DVTs is very low. So there's normally no indication for long-term, let's say, anticoagulation. The risk of recurrence is 1%. Just a reminder of the causes intend to be either primary or secondary. Secondaries intend to be secondary to CVC lines. Primary, they could be either unprovoked or thoracic outlet syndrome. Unless you see it in young people doing exercise, heavy exercise, they come with them, let's say, upper limb.
Go to the last slide, please.
So conclusion, it's rare, but very relevant to all of us as clinicians. We should have high suspicious rate. Most of them, they would need anticoagulations, but attention for the liver disease, attention the PVT is chronic. Data are mostly retrospective, prospective, but for the DOAC, they are as equal, as effective as a warfarin. Obviously, limited evidence, but growing. And don't forget thrombophilia screen, other tests like JAK2, BNH, depending on the type of unusual site thrombosis. I think.
Thank you so much.